Interventions with a King. Discussion and commentary based on articles from JACC, Cardiovascular Interventions.
I'm Spencer King, editor of JACC, Cardiovascular Interventions. Welcome. We are visiting today with Dr. Raj Mekar from the Duke University faculty, who has a paper of great interest to us pending in an upcoming issue of JACC Cardiovascular Interventions on TIMI flow assessment in patients with cardiogenic shock. Welcome.
Thank you, Dr. King.
Now, tell us, we know that TIMI flow is important in acute myocardial infarction. Tell us about that and tell us what you've learned about shock patients.
So we know about the prognostic importance of TIMI flow from the GUSTO-1 angiographic sub-study that showed that TIMI 01 flow was associated with 8.9% mortality compared to 4.4% with TIMI 3 flow. Similarly, we have looked this into the PAMI study where it showed that there was a difference in mortality that varied from 2% in patients with TIMI 3 flow versus 27% in patients with TIMI 0 flow and 20% with TIMI 1 flow.
So a lot worse outcome with the without good normal flow.
Absolutely.
Yeah.
There were no good studies focusing on this subject in the shock population, and therefore we utilized the ACC-NCDR CAT PCI registry data, and we showed that similar inverse relationship with TIMI flow existed even in shock patients. However, this time the mortality variation was very high. For example, people with TIMI 0 flow had a mortality of about 65 to 66%. TIMI 1 flow was about 60%, and 50% with TIMI 2 flow, and 26% with TIMI 3 flow. And so there was a wide variation in mortality.
So if you're successful in getting the artery open and flow normalized, you have a much better survival in this NCDR database.
Correct.
Which, by the way, is very nice that the DCRI is now managing that, and I think is a huge resource for us. So what can be done to, is this just a predictor and we have to live with it, or is there anything that can help us to improve the outcome of the shock patients by improving this TIMI flow?
So there are a few things that we learned from the ACC-NCDR. First of all, balloon pump was utilized only in about 50% of the patients. Improving the use of balloon pump perhaps has a role in improving TIMI flow and perhaps outcomes. The second thing is that 2B3A use was very low. Only 40% of the patient got glycoprotein 2B3A. And there are data observational, albeit in shock patient. Cleveland Clinic Registry had shown that stent plus abscesimab improved 1-year outcome. Similarly, 25 patients in Admiral had cardiogenic shock, and treatment with abscesimab showed a trend towards better outcome, 9.1% combined event rate at 6 months versus 28%. And then in Pursuit, 237 patients developed cardiogenic shock during the trial, and people who were treated with eptifibatide had a much better outcome. So improving the use of 2B3A agent is another way. People are very reluctant when patients are hypotensive to give intracoronary nitroprusside and nitroglycerin or calcium channel blocker, but using high doses of adenosine perhaps may be important in this group of people. And then finally, it remains to be established what is the ideal revascularization strategy is, whether it's PCI, especially in patients with multivessel disease, or CABG. PCI theoretically have some advantage and some disadvantage. Advantage is that it is very easy, logical to perform. You don't require to move the whole team, but there is a chance of distal embolization, chance of side vessel closure, embolization leading to closure of collateral vessels, and incomplete revascularization. only 23% of patients who underwent PCI in shock trial had complete revascularization.
So we've got a clear indication that if we're going to help these shock patients, we need to achieve TIMI-3 flow. And to do that, you've mentioned a host of potential therapeutic options that might get us there. We look forward to your paper very much, and I'm sure our readers are going to be excited to read this paper in an upcoming issue of JACC Cardiovascular Interventions. Thank you very much.
Thank you for having me here.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.